Bonjour à tous. On va pouvoir...
Let's get back to work then, after that good meal. I'd like to firstly thank the organisers of ATHS for inviting us and to talk about prisons. Yesterday there was a workshop about prisons, and there's another one tomorrow. And we're proud to be here to present this workshop with Marie. AHOUANTO-CHASPOUL. It's with great pleasure that I'm here with you. I'm advisor for national prisons, so I work with the Ministry of Justice. Can everybody hear me better now? I have been working for a year now for the Ministry of Justice, and in France there's a significant amount of people who are in detention are there due to problems linked to their consumption of substances, and in detention there's an amount of consumption which is non-negligible. There's a report by the where urinary samples showed that there was a lot of substances consumed in prison. The ministry is thinking about how to implement a strategy in cooperation with the Ministry of Health. And since 2014, they've been trying to implement a strategy for reducing risks and tension in prisons. This work is difficult. I think it's important, therefore, to be here with you today and to work together on this subject. My name is Fadi MEROUEH, and I work in Montpellier, and I'm president of a European Federation of Health in Prisons. And it's at this conference that I've been able to speak to Mr. Mahada, who's going to talk to us about what's happening worldwide. We're going to talk about France, of course, but we will also talk about the Lisbon and the south of Europe. And the European office. Then Michel CELSE, who's here with us and who's going to talk to us about identifying hepatitis and infectious diseases in prison, and Camille BALLESTER, who during lockdown we had to think about how consumption was the type of consumption prisons. So the speakers will each have 15 minutes to talk, and that will include questions as well. So I'd like to now give the floor over to Ehab SALAH, who's going to talk to us about the prevention, testing, treatment and care of infectious diseases in prisons and other closed venues.
Fadi, I'm going to speak in English, so please, if you need to, please put your headsets on. Thanks for having me today. This is a great honor to be with you today in this important event. My name is Ehab, and I work for the United Nations Office on Drugs and Crime, UNODC, in the head office, in our headquarters in Vienna, Austria. What I do is I'm the coordinator for the UNODC work on HIV prevention, treatment, and care in prisons and other closed settings at the global level. So maybe in these 15 minutes, as Mr. Fadi said, I will try to take you through where we are right now, the latest data, the current situation, as well as what's new in this regard and what we need to do to reach our targets. So let's get to my slides. And of course, after my presentation, if you have any questions, I'll be more than happy to respond to your questions, of course. Thank you very much, and let's start. So when we talk about prisons, we all know that the prevalence of infectious diseases in prison settings is higher than in the community, and this is for many factors you are aware of. But let me try to shed some light on these facts and figures with you, and we call it the vulnerability of people living and working in prison settings to infectious diseases, including HIV, tuberculosis, hepatitis C, hepatitis B viruses, sexually transmitted infection, and definitely COVID-19. And we cannot talk about infectious diseases in prison settings without talking about COVID-19 right now. And of course, the major factor that contributes to the high prevalence is the overcrowdedness, or the occupancy rate in prison settings that's higher than 100%. And this is one of the major factors that the world is suffering. And I can tell you that the majority of countries in the world, they have prison occupancy rate more than 100%. In addition, some countries, they have occupancy rates more than 400%. And this is alarming figure. If you think about COVID-19 and you think about physical distancing as one of the major preventive measures for COVID-19, think about people in prison. Think about the overcrowded prisons. And here I'm talking about really overcrowded in means of, in many cases, physical distancing in prison settings is not an option. And this means that an outbreak of COVID-19 may start. And it happened in many countries that the main outbreak for COVID started in their own prison settings as well. So overcrowding is one of the major issues that contribute to the transmission of bloodborne infection, sexually transmitted infections, as well as droplet infections like COVID-19, of course. The second thing is the overrepresentation of key population, and this is also another legal or punitive issue that contributes to the higher level of, or the higher prevalence of HIV in prison, because in some countries in the world, most at-risk population, like men having sex with men, people who use drugs, sex workers, they are overrepresented in prison because they are criminalized by law. So it makes sense that they are higher or overrepresented in prison than in the outer community. With this overcrowding and with the overrepresentation of key population, you will see that in many countries, there also the health system in prison is weaker than, or the health profile in prison is weaker than the community. The profile of the health of people in prison is weaker than the community. In some countries, the health profile of people in prison, because they are coming from deprived communities or marginalized communities, they need more to reach our target for health. So the health profile for people in prison is lower than the community. In addition to that, lack of resources. So in many countries as well, health is not a priority, security comes first, and the budget or the funding for health services in prison is not as it should be, and this leads to the transmission or the low level of services provided in prison settings. Living and working conditions, and again, as I said, my presentation is a kind of a global one, and still in many countries that the living conditions, the food, nutrition, the ventilation, the sleeping, accommodation, all of these things are coming from the previous era, and the prisons are neglected. And this is why you'll find that ventilation, for example, is bad inside an overcrowded prison cell, and you can talk about the prevalence or the transmission of airborne or droplet infections in this regard. In some countries as well, you will see that the prison health is separated from the public health. Like, it's not connected. They don't speak to each other. There is no clear linkages between prison health and public health. And this is very clear again when it comes to COVID-19. I remember very well that in the beginning of COVID-19, early 2020, we received calls for help because all the countries started what we call it the national preparedness and response plans, and prisons were not there. And this tells you the linkages between community and public health. Last thing I want to talk about is the stigma and discrimination. And I'm sure you know about stigma and discrimination. It's still very high among people in prison settings, even including social stigma, self-stigma, healthcare provider stigma, or in healthcare facility stigma. All of this stigma is much higher among people in prison settings. And I would always use this example when we think about a woman who used drugs, living with HIV, and in prison settings or released from prison. You see, we call it multifactorial or multiple layers of stigma that, of course, this person will think twice before accessing health, and also she might be suffering from discrimination when you start to asking for health. Again, violence in prison. Some people in prison, they are subjected to kind of sexual or physical violence, and this, of course, contributes to the higher level of infectious diseases, including HIV in prison settings. So this is, in a nutshell, the vulnerabilities of people in prison, and now we talk about the figures, facts and figures, where we are. And here I'm gathering different sources of data about the prevalence of infectious disease in prison settings. Basically, we have a systematic review conducted in 2016 and published in The Lancet about the HIV, TB, and HCV in prison settings. We also have in UNAIDS, in the United Nations Joint Program, we have the Global AIDS Monitoring System where we receive data. So it's a kind of mix of data from different sources. But in summary, the prevalence of HIV in prison settings in general is 4.3%. What does it mean? It means that people in prison are 6 times more likely to be living with HIV than adults in the community. This is the vulnerability translated into numbers here, as you can see. And HCV, and I'm hearing a lot of HCV this morning in the presentations, amazing. I was listening with great interest. And you see that at a global level, HCV, hepatitis C virus prevalence is 15.1%, while hepatitis B virus is 4.8%. Active tuberculosis is 2.8%. And also, when we talk about people who use drugs in prison, there is no clear global data on the number of people who use drugs in prison settings. However, some experts estimated that this number represents like 30% of the total number of people using or people in prison settings are there because of drug-related offenses, 30%. And also, some experts estimated that in some countries where people use drugs are more prevalent, the prison population is composed of more than 50% of people who use drugs. This is where we are when it comes to figures. COVID-19, we still don't have a global or estimate of the number of people infected or diagnosed positive with PCR for COVID-19 in prison settings. I remember I read a report published in July this year, and it's indicating that 550,000 people got infected with COVID-19 in prison, like close to 500,000 people. If you think about this number, and you think about the total number of prison setting or people in prisons at any given time, which is 12 million. So 500,000 of the 12 million got infected with COVID-19. And I leave it to you to think about the high prevalence of COVID-19 in prison settings. In one country, there was a report that the country has 10 different outbreaks of COVID-19. 9 of the 10 outbreaks happened or took place in the prison in this specific country. So before we talk about the services, I would like to highlight some targets or the international standards we have right now. And the first thing, of course, is the Sustainable Development Goals, also known as the SDGs. SDG number 3, and the output number, or the output 3.3, is talking about ending AIDS epidemic as a public health threat by 2030. So the global leaders committed to end the AIDS epidemic as a public health threat by 2030. This is a commitment that came from the Sustainable Development Goals. And one more, which is the Nelson Mandela Rules. I'll talk about it. I'm sure you heard about it. The Bangkok Rules and the UNGAS document on drugs. UNGAS is a United Nations General Assembly special session on drugs, and the outcome document was adopted by the General Assembly in 2016. And it's promoting alternative to imprisonment for people who use drugs, small offenses, according to the national legislations and context. So one of the documents that's talking about promoting alternative to imprisonment is the outcome document. Why I'm saying the General Assembly and UNGAS? Because this is the world, the countries, the world leaders are discussing and coming together with these recommendations on dealing with health issues related to people in prison settings. Nelson Mandela Rules, for those who are not aware, this is the United Nations Standard Minimum Rules for the treatment of prisoners that has been adopted by the United Nations General Assembly in December 2015. And these rules, it has a lot of health-related rules. It's very important that the global or the world leaders agreed that people in prison should have the same standards of health, equitable or equivalent to those provided in the community. These minimum standards is also promoting that healthcare services in prison should be integrated into public health, linked to public health, provided free of charge without discrimination based on the legal context. This means that people in prison should have exactly the same services available in the community. And the legal situation has nothing to do with this. Health should be separated from this. And this is clear. But still, we still have a long way to go to make sure that this is happening in the reality. And the other thing I want to refer to is the Bangkok Rules. This is the United Nations General Assembly Rules for non-custodial measures for women offenders, which is also talking about the gender perspectives and how women should deserve more care, especially when it comes to healthcare services. Because many experts said that health in prison is designed by men and for men. And usually, women in prison settings are left behind, or the services are not accessible, available, or even when available, it's not acceptable for women in prison settings. I still have some time. 5 minutes. And when we work on guiding, we have guiding principles. In short, our work on HIV and health in prison settings, we have two major guiding principles. Number one is the human rights. The right to health is guaranteed, and it also should be as the same as in the community in terms of medical ethics. It should be the same, exactly the same, with the informed consent, confidentiality, voluntary. And people providing services in prison should protect this right and also try to, as much as possible, to avoid the double loyalty. I keep the confidentiality of my patient in prison settings as well. The second one is the public health. And this is why what we promote is the prison health is the responsibility of healthcare providers on both sides of the prison walls. This is what we believe. It's not the prison healthcare providers only. Community should also provide support to that. What's new here is the global AIDS strategy. So we developed with member states, we developed the global AIDS strategy in March this year. And we have a lot of issues related to people in prison. We have a lot of work. We have a lot of targets. This strategy we have, it's global, and we need to work together to achieve it. And it has a lot to do with the inequalities. Of course, people in prison is one good example to talk about inequalities. In order to be able to reach our targets, we need to reduce inequalities. One more new thing, which is in June this year, the global leaders agreed on a political declaration on HIV/AIDS, and it says that addressing inequalities and saying that 95% of most at-risk population, they should have access to evidence-based intervention, including people in prisons as well. This is our comprehensive package of, we know what works, we know the interventions, we know how to prevent and treat and care, provide care for people in prison when it comes to HIV. And UNODC with partners, as you can see, WHO, UNAIDS, ILO, UNDP, UNFPA, we all agreed on a set of interventions that should be available in prison in order to be able to end AIDS epidemic as a public health threat by 2030, including for people in prison. As you can see, we have a set of interventions, including testing, treatment, social care, opioid substitution therapy, needle exchange program, TB, sexual and reproductive health, reducing drug overdose, especially upon release, taking care also of the health staff, the health of the staff, because occupational health for people working in prison is an integral part of the comprehensive package as well. That's 15 key interventions available on our website in all UN languages, I would say, and we know what works. Each intervention has an impact on the HIV epidemic by itself, but in order to get the maximum benefit of this package, you need to implement the full package, like all of them, because they have this synergistic effect, and when you do all of them together, you will get the maximum benefit of this package as well. So let's have a quick look on the services we are right now. And I mentioned the interventions that's recommended by different UN organizations. But what is the situation at the global level? That's a very important slide. I'll stop here for 2 minutes to talk about needles and syringe program, one of the evidence-based intervention to prevent HIV and hepatitis virus among people who inject drugs in prison settings. And you will see that the latest figure we collected from the country reports that almost 10 to 11 countries is adopting this intervention right now. Most of these countries, if you look at the regional part, they are in West Central Europe and North America. And many regions in the world, they don't have these interventions at all. We are progressing, but we are progressing very slow on this regard. I think the most recent country that's adopting needles, that was Canada during the last 2-3 years. And the number is still very, very low on this important intervention as well. Opioid substitution therapy for people who are using opioids in prison settings, still the number is very low compared to the community. Remember, we agreed that people in prison, they should have the same or have access to the same services in the community. But when you see the reality is different, I think 56 countries providing opioid substitution therapy in prison settings as well. Even the entry point for services like testing and treatment in some countries is still not done. And this is why we need to work with all the stakeholders and national counterparts to improve access to evidence-based intervention for HIV in prison settings. I think I covered most of the issues related to COVID-19. And again, we have a lot of publications, tools, guidance document on our website. Just go and visit UNODC HIV, and you'll find a wealth of information. And of course, you can communicate with me if you need any clarification. And please follow us on Twitter. We sometimes post good data or evidence around HIV in prison settings. I leave it there. I would like to thank you again very much, and thanks, Fadi, for having me today. All the best, and I wish you a successful conference. Thank you.
Merci beaucoup, Ehab.
Thank you very much. Are there any questions in the room? Please, we have to remember the ethical rules for care in prisons. I think it's something that we don't really do enough. I think it's good to repeat this so that we actually, so that we implement these in prisons.
Oui. Bonjour tout le monde.
Thank you very much for your very interesting talk. I work partly in a prison in Paris, and I wanted to ask you about the data that you've given. You talk about men and women. Have you any data about underage people, about children, about hepatitis, about these diseases?
One of the major issues we are facing, one of the challenges, is the generation, collection, analysis of strategic information related to infectious diseases in prison. We try as much as we can, but so far, as we speak right now, there is no clear evidence or data that's at a global level collected on HCV in prison settings. Among juveniles, I'm talking about juveniles here, but if we can communicate separately, we'll be able to try to share with you some country-specific data on HCV prevalence among juveniles in prison if available. And I promise I will do that. If you can share with me your email, I'll be more than happy to do that. But nothing at the global figure to represent us.
Alors, moi j'avais une question, je suis désolée, je vais la poser en français.
I want to ask this question in French. Don't you think that the objectives for the developments which the nations set at the end of the 1990s, we had objectives for development which concerned southern countries. Do you think that sustainable objectives, do you think that we're now realizing that we've seen this with the pandemic, or the COVID pandemic? And the last slide, the countries of the South have not had the same momentum. For example, with HIV, there was a World Fund where they created retrovirals, for example. This is the case with ODDs and vaccinations for COVID.
Very tough question, I would say. Understood, and with the support of my colleague, thank you very much for translating, that you want to say that there is some discrepancy between North and South, developing, developed, and all of that. But in COVID-19, right? Or in general?
My English is very bad. I will speak about the objective of development, ODD.
Oh, okay.
And les objectifs de développement durable.
Mm-hmm. Right. Let me try to answer this point in two different ways. Number one is this is global objectives. Sustainable development goals are for the whole world, and it's not specifying whether this is North or South, developing or developed. No, the whole world should reach these goals by 2030. However, in order to reach that, we need to have what we call it the equitable access. Or what does it mean, equitable access? Is in order to reach this level, I'm here, so I need more to reach this point up there. This is what we mean by equitable. Equitable means that some communities, they might need more support to reach the targets. I hope I answered your question. And definitely we know that the HIV, for example, is higher, the prevalence is higher in some countries in sub-Saharan Africa, for example. This is the south part you are mentioning. And for me, this means that we need to provide more support to those countries in order to help to reach the target of ending AIDS epidemic as in 2030 as a public health threat. This is what we mean by equitable support. Thank you.
Merci beaucoup de votre présentation. Dans mon travail avec l'OMS et MCDB, j'ai appris sur les frustrations par rapport à faire des recommandations au niveau européen et ne pas avoir beaucoup de leviers pour forcer les pays à les mettre en œuvre. C'est très difficile.
Conditions and recommendations that UNODC has, I'm curious to know what strategies and what outcomes you've had in getting prisons to actually put them into place, and what outcomes have been found as a result of putting them in place. Yeah. So you talked about these guidelines and the Mandela rules and these other things that are recommended for prisons to implement and abide by. What success have we had in having prisons actually put them in place and adhering to them? And what leverage and what strategies are there to get them to actually do that?
Thank you very much. Yeah, this is many questions in one. Thank you. And we talk about COVID or in general or HIV? COVID, okay. Right. 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 Okay, let me try to use COVID as an example, and maybe we can use this. You know, we cannot apply everything to other infections, of course, but let me use COVID to respond to you. For COVID, we have clear strategies, and this is WHO, especially our colleagues in Copenhagen, the Health in Prison Program, working with us. And we started to respond to countries with strategies. And the first thing we did is we had guidance, technical guidance to tell us what to do in pandemics like this. So we came with the technical guidance and position papers and tried to translate this into national context. That's one. Second thing we did is the reducing overcrowdedness as much as we can. And in this, we have so many strategies, including one, alternative to incarceration or alternative to imprisonment. We help countries. We already have tools to develop this, but it wasn't followed. So this is why we call that COVID-19 has exposed the situation in terms of the long-standing call for alternative imprisonment was neglected for some time. So we do the support countries to do alternative to incarceration or imprisonment. Also, some countries, they went for release, early release, compassionate release for a specific group of people in prison without compromising the public health and safety and security. And some countries also did something which I like, and I think this is one of the good practices, is putting some sentences on hold for a specific people for a specific time. And I think this is one of the good practices, because when we talk about infectious diseases, especially COVID, for example, I'm not sure about the population dynamics and moving people from place to another, and this might also increase the possibility or the vulnerability of infection. So the best way is to keep them where they are and reduce the vulnerability. And putting or suspending specific sentence for specific people, I think one of the good practices as well. That's one of the strategies. After this, we did training, I think from March to February 2020 till the end of the year. Every day we have training, like 10, 12 trainings. We train healthcare providers and prison staff on how to prevent and respond to COVID-19 in prison, how to do all these preventive measures, especially healthcare providers. Then we started in some developing countries to provide the materials and to provide them with all these, the goggles, the aprons, and all of these things. We started immediately the procurement for that. And one of the good practices is in some countries, the people in prison themselves, they started to make in their vocational workshop, they started to make the mask and hand sanitizer to use it for them, for the staff, and even for the surrounding community. Now, the last thing I want to answer your question with is now we don't wait for another pandemic. We want to deal with health disasters in general. COVID was a pandemic, was not good, but it's not the end. We should expect others. We shouldn't start from scratch and reinvent the wheel every time. We need to have a clear strategy for other health or natural disasters for people in prisons, and how to deal with it. Thank you.
Merci beaucoup, Ehab. Merci beaucoup pour cette...
Thank you, Ehab. Thank you for this international vision. We now give the floor to Linda. Linda is not present in this room, but will follow her presentation on Zoom. So Linda works in Lisbon, and more particularly, she works with the EMCDDA, and she's going to talk to us about the figures for prisons in Europe. And she will be able to answer your questions afterwards. So I'm very happy to present the latest data available on prisons and drugs. These data were published only recently by the European Office for Drugs and Drug Addiction. I'd like to thank the organizers. In particular, I would like to thank Dr. Fadi MEROUEH. This presentation is made of 8 parts. First of all, an introduction. Then I will talk about epidemiology in prison. Then I will continue with the availability of drugs in prison. Then we will deal with the scientific evidence of drug availability. Then I continue on the market of drugs in prison, and I will conclude with the possible consequences for policies, interventions, and the challenges for the future. Based on the latest data from 2019 in Europe, 30 countries were part of a survey, and we had a total of 856,000 people in prison. That is 142 persons for 100,000. This is a little more than in the USA or in the USSR. Or sorry, in Russia, excuse me. But as you can tell from the right, there is a big difference between countries in terms of population, with obviously major differences between Western and Eastern Europe. So what is the relationship now between drugs and prison? There are, in fact, 3 major groups to take into account. One group of people in prison are people who were sent to prison because they were trafficking. That's 17% of the population in jail in Europe. Then we have people in prison for crimes or offenses that are directly related to the use or consumption of drugs. And then one last group of people who are in prison with absolutely no relation whatsoever with drugs, but who have different types of problems. So there's still a high prevalence of consumption of drugs before prison. As you can tell from this chart, there is a pretty high rate of prevalence, particularly for heroin, where the general population amounts to 1%. The use amounts to 1%, whereas in prison it's as high as 30%. But as you can tell, there are major differences between countries. These variations are related, for one part, to the different types of consumption in the population, but also to differences in the legal systems, in the organization of prisons, and in the methodology. This is the reason why the observatory started harmonizing data and published a questionnaire, which is now available for anyone who wishes to undertake research. So the prevalence of drugs was compared in prison with the same prevalence in the general population. So for the 4 drugs in question, as you can see, we have the population, the general population, and this is particularly high if you see for cocaine and amphetamines. If a person stops using drugs when being sent to prison, still some people may continue or change their consumption. This is why the figures for prevalence can be as high as 30% for heroin and even sometimes more for cocaine. So the major sources are mainly visitors, the post by mail, the staff, but also it can be thrown over the walls or through people getting back to prison. One important phenomenon to take into account is that since 2012 or 13, psychotic substances have been used in prison in 22 countries with, of course, different figures depending on the country. People in prison have a worse health status as compared to the general population, particularly in terms of infectious diseases and psychiatric pathologies. So this is why there is this kind of graph that we can see with a high prevalence of HCV and up to 15% for HIV. This is even higher for people who inject drugs. Another issue is mortality. In prison, the death rate is higher than in the general population for the same age range. And the first cause of death in prison is suicide. Most deaths in prisons are violent deaths. From a French study, 1 out of 10 of these deaths are due or is due to an overdose or an intoxication through a drug, whether intentionally or accidentally. And after quitting prison, indeed, there is also a high rate of mortality, and women are more particularly vulnerable. They only represent 5% on average of the population in prison in Europe, and there are differences, of course, between countries, but there's a pretty high percentage of up to 40% of women being in prison for a traffic of drug, and usually they are extremely vulnerable, particularly when they leave the prison. They're even more vulnerable because reinsertion into society is more difficult because of the stigma they have and because of the burden of children, family, and of the difficulty of getting a job after leaving prison. So what do we do in Europe for drugs in prison? We can categorize the intervention related to the use of drugs in prison in 3 main groups. First of all, when the person is included in prison, there can be a health checkup and a detoxification. Then during the time in prison, you can, of course, organize a treatment with different modalities and different interventions to reduce risk. In some countries, there are indeed a certain number of interventions for training and information. When getting out of prison, prevention is mainly related to preventing overdoses and social reintegration. So this is quite clear when it comes to a reduction of the consumption. If we take a look at the literature, there are indeed references available for all these interventions, but we get much less scientific evidence and literature concerning intervention in prisons as compared to the general population. Now, this is obviously necessary. It is important to have a literature or a bank of data which is more specific to the prison population. In Chapter 6 of the report, interventions for which we do have evidence about their efficiency with a substitution treatment, for example, whether in prison or later in the community, tests for infectious diseases, health promotion, etc. are available, but we don't have many evidence for other interventions. This is the reason why the teams of Stockholm and Lisbon have been working together to produce a report and recommendations in terms of public health for the control of infectious diseases in prison in particular. And this report also included a group of experts with someone from that particular sector. Now, this graph shows the types of interventions available in different countries, in 30 countries, actually. But as you can tell, most countries have implemented testing interventions for infectious disease and also training for the staff and substitution treatments. This is now available in 29% out of 30. Only Slovakia has no availability. And if you take programs like free syringes or take-home naloxone, this is now available. Now, this graph is based, of course, on the information that are sent to us by the national focal point for the observatories. But we don't get any information as the current implementation of these systems, neither do we get information on the actual coverage of these interventions. We have here the example of substitution treatment. As you can see, the percentage of the population in prison who gets a substitution treatment is usually lower than 10%, and only 4 countries have a percentage higher than 10. So coverage is not the only problem. We also have to consider the delay in introducing these interventions. Indeed, the introduction of substitution treatment in the community at large is presented here in yellow and in prison in green. So as you can tell, there is sometimes a 20 years gap between introduction in the general population and introduction in the population in prison. So what are the political implications of all this? The idea, of course, is to identify the crucial points, and they can be summarized as this. First of all, prison and social vulnerability are highly linked. People who are in prison with an issue with drugs have indeed a higher social vulnerability. So it is important to offer equal care to them, and this is, of course, based on international principles, offering equitable care. That is, that people in prison should be allowed to have the same type of care than the general population. Second point, prison and community, the prison population and community population are highly linked because they are in contact. So working in prison means that we have to work at the same level as any other public health intervention. And for this, we need to have a continuum of care before, during, and after prison. Another point, which is important, is that prison authorities always have a difficulty to establish the balance between care and control. So this is the reason why it is important to have an overview, because all the actors involved in prison interventions should be given the possibility to be coordinated. The next point is the decrease in the coverage. It is certainly urgent and necessary to further increase the coverage. One more point is alternative solutions. The report didn't really get into details in terms of alternative systems, but it's certainly very important. And we have to consider the balance between the cost and the benefits of being in prison. So as we saw, there is still very little information and very little scientific evidence. So it is important to improve both the quantity and the quality of interventions and to make sure that they compare well between different countries and different prisons. You will find this information in our website, and you can also download our paper in English. It's only in English right now, and we are hopeful that we will have this report translated into other languages. I am, of course, available to you for any further questions. Thank you very much for your attention. So thank you very much to Linda, who usually speaks either English or Italian and sometimes Portuguese. So Linda, can you hear us? Yes, yes, I hear you. Can you hear me too? So do we have any questions for Linda? Well, this was obviously very clear. It seems that no one has a question for you. No? It's going, gone? Okay, no question. Thank you very much, Linda. And we'll talk to you soon. Thank you very much. Have a nice conference. We mentioned the COVID-19 pandemics in France. When the pandemics broke out, a certain number of prisoners were released. We had something like 70,000 prisoners before the pandemics, and in July it was 58,000 prisoners, and now we're back to 69,000 people. So as you see, this gap was immediately covered. And as to the vaccination rate, it's, I would say, 20 points behind in prison as compared to the general population. So this is important to know, and I'm very happy now to leave the floor to Camille BALLESTER, who works at Villeneuve Lès-Maguelone and who's going to give us a focus. Good afternoon. I'd like to present to you a study we did in our department with my colleague who's not here today on the consequences of the first lockdown on people incarcerated in the prison next to the city of Montpellier. And in particular concerning the consumption of so-called psychoactive substances. So we have a pretty high turnover in our jail, which is called a maison d'arrêt, actually. As we saw before, our population, in fact, is quite precarious. We have indeed a high prevalence of drugs as compared to the general population. For tobacco, for example, it's 70 to 90% prevalence. Cannabis is between 30 and 50%, as opposed to 11 for the general population. Cocaine is 8 to 19% versus 0.9% for the general population. And opiates are between 7 and 19%, as opposed to 0.9% in the general population. Of course, there are multiple reasons to this. The detainees need to have a space for free space for them. It's also because they feel anxious. It's also to spend time and to have some moments of friendliness between them. Studies considered that during the lockdown there was more boredom and isolation with an increase of anxiety, but there was also a lack of availability for some substances. So during the first confinement, the Ministry of Justice had banned all visits, as well as its suspension of the socio-cultural activities. There was only one walk outside instead of two. So we tried to consider what was the impact of the lockdown on the consumption of substances. For that, we did a transversal observational study over 1 day. The questionnaires had been distributed to all the detainees. Patients had to be major, speak French, and be literate. So we have the social demographic data, the assessment of the stress level and the depression level before and during the lockdown. We also assessed the consumption of tobacco, cannabis, OH, cocaine, opiates, and psychotropic substances. There was a follow-up by the health care department, and at the end of the questionnaires, we had open questions. So on the 6th of May at Villeneuve, we had 713%, among which 6 minors, 37 refused to fill in the questionnaire, 31 were non-French speakers, 14 were illiterate. So we distributed 619 questionnaires, and we had, in fact, only 166 that could be assessed, as 450 of them were not given back to us. 2 were totally nonsense, and 1 was void. The average age was 40. 1/3 of patients had done some college, comprehensive school studies. Before the lockdown, patients were in a double cell, then in single cells. We also asked them if they were able to leave the cell during the lockdown. 41% didn't leave the cell at all during the confinement, during the lockdown. As to consumption, 68% of patients used to smoke tobacco, 30% cannabis, and more than 5% used opiates. As to addictions, 17% of patients said they had an addiction, but never mentioned that to any healthcare professional. So that was the assessment of the stress level before and after the lockdown. And on the right, we have the depression level. Same thing, we have an increase of the depression level during lockdown. As to the changes in the consumption, results were difficult to consider because of major standard deviations, but we didn't find any major change in the consumption, in the use of those substances. 40% of patients had increased their use of cannabis. For tobacco, 40% increased their smoking, whereas 40 didn't change their habits. And quite significantly, cocaine also was decreased by in 60% of subjects. Now, as to the open questions, we asked them what they considered a reason to increase their use. Most mentioned stress because of COVID, but also stress for their families. They feared their families to be contaminated. They also mentioned boredom because they could only go out for one single walk a day. There were no cultural activities. Work was reduced as well. So they were locked down in their cell, actually. So they felt isolated, far from their families. And of course, they also mentioned the positive effects of substances to decrease stress. So which factors could be related to a decrease of use? Well, again, they mentioned stress because in fact they feared they might be made more vulnerable and therefore more at risk of COVID contamination. They also mentioned the unavailability of substances, in particular cocaine. The cost also had increased during the lockdown period. Everything was at a higher cost. And also some mentioned that they really felt like quitting. So we asked them how they managed that change in the use of substances. So they said they found some compensations, they made more sport, or they tried to entertain themselves differently. And they also mentioned treatments that were given by the healthcare unit, such as nicotine substitutes or psychotropic agents. So we didn't see a major change in the use of substances apart for cannabis, where consumption happened to be higher, and this was also the case for the general population. 40% of smokers increased their consumption, which also is in conformity with the other data we gathered. And as to behavioral addiction, 17% never mentioned that. As to the factors that have had an impact on their change in consumption, all of them mention stress during lockdown, just as for the general population, because lockdown was indeed a factor of stress for everyone. They all mentioned feeling insulated or isolated, far from their families. They mentioned boredom. Consultations for addiction were also spaced to avoid concentrations of patients, and some told us that they lacked these consultations. And of course, they also mentioned the lack of availability. Of course, there are biases in this study, a bias in the selection. The patient who answered our questions at a mean age of 40, knowing that the mean age in that population was 33. We also have a bias. That's the representativity bias, yes. As to selection, there was a bias. The questionnaire was handed out to everyone. So the bias may be due to the fact that some were accompanied by a steward, so maybe the presence of this person may have biased their selection. Some also gave us obviously biased statements, and there may be a bias in the interpretation. As to the hypothesis and perspectives, of course, the adaptation of the means of supply was necessary for them, and this could be a reason for us to adapt our management in such lockdown periods, and to perhaps continue with further screenings of behavioral addictions. Thank you. Questions?
Bonjour, merci beaucoup pour la présentation.
Thank you for this presentation. This was quite interesting. I have a question concerning substance use. You talked about cannabis, cocaine, and others, but why did you restrict yourself to these substances, knowing that you had open questions? During the last presentation of Mrs. Montanari, she mentioned, for example, synthetic products, and also why did you opt for opiates, generally speaking, without distinguishing between the strong ones and the weaker ones? In the last report of addictovigilance in Toulouse, Prevalence, we can read that initiation usually takes place in prison. I guess this was just based on the questionnaire. You didn't check the urines, etc. Yes, indeed, we didn't use anything but the questionnaire, and we selected substances by not being too, I would say, too exhaustive to have, I would say, a more overall answer from these subjects. Of course, it would be interesting to use your suggestions. Can I just add, 2 years ago, we did a survey with EMC DDA on the products, the substances used in prison. And we opened the whole list of substances. And we observed that some of the prisoners said, but what is this? I never heard of that. So, sometimes they may use synthetic substances without knowing it, actually. The actual danger today is cannabis. Some chemists add synthetic substances into cannabis. Some 5-6 years ago, they were just having some injected eyes. Now we can observe side effects that we didn't see before, like paranoid fits, etc. So this may be due to the products the substances being added into it. Unfortunately, there are not many of them in prison right now. I'm saying right now. We don't know about the future. But when we asked the laboratories if they could trace new synthetic substances, they told us that we had to specify which ones, because they cannot track or trace them all. Well, it's the same with us. When we have a survey in terms of addicto-vigilance, on the place of substances among the younger population, there is a paradox because, of course, the general population has had some idea, some hint of what it is to be locked down. So we've had to find quick adaptations for all drug users. And that was a problem. Usually a user moves about to get syringes, etc. Now this was not possible during the lockdown. So they had to manage their own cravings. So we've had to consider having naloxone to prevent overdosage, etc. So when we prepared a set of questions, we couldn't do much more than just open a box in open questions, not to limit substances. For example, nitrogen protoxide is one of them, which we never thought about. The last question we asked was that we wanted to insist on the creativity of students during the COVID lockdowns. But in that case, there was no activity, no visits of the families, etc. So what did you do for the prison environment? Did you could you palliate for that, for those missing elements? I don't know if you have had a lot more telephone calls. I know that in most prisons, phone calls were allowed more than before. I know that sometimes some collective sessions could be organized with a theater crew, for example, where they could introduce some poetry into the prison. So by cutting all the, I would say, usual activities, were you able to develop more creative activities, or was nothing done at all? Well, we have what we call the health doctrine, which is prepared by the Ministry of Health in cooperation with the Ministry of Justice. This is usually very restrictive. People have 2 hours walk, 1 in the morning, 1 in the afternoon. Most people, in fact, spend 23 hours out of 24 in their cell. So there was no work, there was no schooling either. There was, well, we mentioned minors, but schooling was also stopped. Only visits from the lawyers were maintained, and there was absolutely no contact with the outside world. So all prisoners were given 30 euros to spend on telephone, and telephones were installed in the cells, actually. So French prisons have started to fit cells with telephones, with, of course, limited numbers to call. One last question before we stop.
On substance use among prisoners and in the general population, is there any data around the number of people who recently left prison or are still in prison who developed an addiction in prison? So they came in not addicted to drugs, but they left with addicted and severely impaired as a result of using as a coping mechanism in prison, particularly around COVID. We know a lot of people started using around COVID as a coping mechanism as well, outside of prison. How many people left prison addicted?
Merci. En fait,
I believe, well, I think that the good point about the survey we did it in Villeneuve is that the population in prison, in our prison, reacted in the same way as the general population. 40% increased consumption, 40% decreased, and a certain percentage also started using substances because of the stress of COVID. Some started drinking, some started smoking, etc. So I believe that COVID, at least in the first period, came as a surprise to everyone. And I believe that all human beings, whether in prison or not, behaved in the same way. We reacted in the same way. And I think this is what is interesting with this work. It was not the second and third bout of COVID, because in between people found adjustments. But the behavior in prison was the same as the general population. We found exactly the same percentages. So I believe the stress of the first bout of COVID showed that every one of us had the same type of behavior. And this is quite interesting from a human point of view. We were all the same, and that's quite interesting. But I do believe, indeed, that between 1 and 10% of people started using substances, but I don't know if they became addicted.
Question courte, parce que le temps court. Bien, nous allons passer à la prochaine présentation. Je ne vous présente pas Fadi MEROUEH, je crois que tout le monde le connaît. C'est le médecin de la Villeneuve Lès-Maguelone, de l'unité sanitaire. Vous savez que chaque prison en France possède une unité sanitaire rattachée à un hôpital depuis la loi de 1994. Alors Fadi va nous parler de la buprenorphine long-acting. C'est quelque chose dont on a eu déjà une séance mais il va nous parler surtout de son expérience.
And he's going to talk about his experience in prison. And this is perhaps the first unit in France which has used this treatment. Thank you very much. This morning, many of you attended the plenary session on Buprenorphine, which is long-acting, which is now first in France. This has existed worldwide for several years now. We're just beginning in France, however, to use this, and since May. And by using this medicine, I've discovered something else, and that's what I want to share with you today. The question I am asking, if this could not be used as a risk reduction tool. The reduction of risks designates a series of strategies aimed at limiting the risks and damages, whether they be health or social, linked to a specific field. For example, it could be putting a helmet on if you're on a work site. This exists in all fields, but health included. So, for example, if you're in cardiology, diabetology, or pneumology, in all the branches of medicine, we do risk reduction. And so when we talk about reducing risks for substances, this is something new, whereas it should really be automatic. And if we do this, it's not just for the family, for the person itself, it's also for the family, the society, with legal consequences as well. So this should apply everywhere and to everybody. Why risk reduction in prison? Well, there were doubts about drugs if there were any doubts about drugs in prison, I don't think that I don't know if you've read the report by the FDT, which shows that today we know for definite that drugs are used in prisons, that all drugs exist in prisons. We looked at wastewater coming out of prisons, and all the ministries now agree that this is the case. And in addition to drugs, there is other practices. It's not just smoking a cigarette or cannabis. We know that these practices exist because when we talk in local newspapers about, they say that syringes have been found in certain prisons. It's no longer a secret that there are syringes in prison, and not just in France, but as Linda said, in all countries, this problem of injections exists everywhere. We may ask the question, is this something that can be done in prison? Here are some laws on the slide from 1994, 1996, which authorized the equivalence. And in the final law from 2016, it said that risk reduction should take place both in prison and outside. The application decrees don't always exist. But the only decree that exists today to reduce risk is the decree of 2005, which all addictologists know, which is the only French law which enables risk reduction. The law says everywhere, wherever users may be. So if they're in prison, that's also covered. So there is a decree that exists. I'd like to go back over the kit that Ehab SALAH presented. This is the latest version. The first version is this one, and it was updated. It was ratified by all countries of the United Nations, including France. This convention, where they talk about reducing risks in prisons. And when we see the 15 points in this list, the perhaps 10 or 12 in The only country where 15 are applied is Spain. There's 12, 13 applied in France, because we haven't managed to implement this for syringes. And this list will be completed, because now there's naloxone, which will be added very soon to nicotinic substitutes, patches, or there will also be PrEP, which is something that's been talked about more and more. Now, general practitioners can do this. The specificities for women. We shouldn't forget that men and women may have different characteristics. For example, sanitary towels. This is also about reducing risks. Crack pipes. We have current minister who want to put all people on crack in prison. So there are lots of tools available. And my subject is to long release buprenorphine. It's in liquid form. You have a photograph here. When it's injected under the skin, you have like a gel that forms and which is released over time, over a month. The gel is released slowly, giving a daily dose as a substitute treatment. This is how it was implemented in prisons. And then we tried to see the interest of this. It arrived in May. What's interesting for us, apart from the therapeutical characteristics, is the stabilization of the doses. If you have 8 milligrams, you know they're going to get 8 milligrams. They can't forget to take it every day, at the same time every day. They're eaten before or after. There's no stigmatization, because this is something that we can see with certain people on drugs in prisons. There's no possible racketing, because people, when they go back into their cells, it's injected so they can no longer do anything with this. There's no misusage, because it's practiced, it's done only by a health professional, and so it can't circulate amongst different prisoners. Why am I talking about risk reduction then? Because the interest, the weak point is when people leave prison, they come out and have often without any preparation. And even when when a patient manages to get an appointment, there's a lot of uncertainties that exist. Today, this treatment, once it has been given, for 1 month, we know that the person is okay. So there won't be any overdoses when they immediately come out of prison. Of course, the risk, the biggest risk is in the first 48 hours. There's a consortium which was created called My First 48 Hours Out, which alert everybody saying, be careful when you leave prison, that this is where the risk is. And this was implemented in France, and especially in England and Canada. And I think that if we give an injection before they leave prison, we can cover that person for at least stopping overdoses and have no interruption in the treatment, this is one of the important things in reducing risks, because if there's no interruption, that means you don't have to find other products. And these were the two problems when when prisoners leave the prison. So today, this medicine can answer these, satisfy these two criteria. Since it's come out, we started to talk about this with patients, with our prisoners, with patients, and explain to them this new form of buprenorphine. It's taken differently. We started in July 2021, and we offered it to all patients. So it was offered to people who they either accepted or not. There were 20 people in less than 3 months who accepted. They always had around 120. There were 17 patients with BHD between 8 and 18 milligrams. So we were able to increase the dose with 7. 3 patients with methadone, they went on to Buvidal because they were fed up of coming every day for methadone. Because it's not distributed in cells, and they were fed up of coming and getting it. And what made me wrecked as well, and the last line, 3, what I call precarious patients who were very often would have gone back into prison because they had no accommodation, no family, no job. And these people will often come back. 6-8 weeks later, they're back in prison. And so I offered these people, so this is 1 injection for you, so at least you're okay for 1 month. They accepted, and the idea is to reduce risks. So the feedback that we've received, and we had feedback of 15 days later with a questionnaire. They were all very satisfied. Nobody wanted to go back, had any regrets. The nurses have more time to give care. So if you take 20 distributions, then that's 2 or 3 kilometers of walking that they've saved. All the wings of the prison, all the corridors, that's 2 kilometers they have saved. So that's a lot of time. Although we've also started to look at co-prescriptions because they're stable in terms of treatment, and of course we can see less racketeering. And this is a question, can this medicine be a way of reducing risks in prison environments? Thank you for listening to me. The gentleman here. Thank you. I'm convinced by everything you've said, but I have a question. Who pays? The hospital pays on the hospital budget. These medicines are professional medicines. In all hospitals, these medicines are available. So, for example, antipsychotics, which are... I'm not very good at with money, but we've proven this out of the next 3 years. If we'll make a saving, we'll make significant savings. So that means we wouldn't have a deficit, because when we know the price of Ibuprofen, we know it's €300. And so that's why we have to think about the question of money. Not only in prison populations, of course, but in the population in general. Is this something that concern? This is something that, or you're just simply, or is this a question that you look at, or is you just? I have two examples. A patient who was released, and who wrote to us, saying, "How can I get this outside?" So we alerted the regional health authority. And I think that regional authority now to provide the means. And the negotiation is open with the Ministry of Health today and the Social Security. In France, we're not used to, like in certain Anglo-Saxon countries, of nurses being able to easily give an injection. So we need to think about the French model, with pharmacists, with nurses and health professionals, to find out how we can, based on the perception, how can we do a prescription and go and get the medicine from the pharmacy without the patients actually being able to get hold of hold of the drugs. You're right, and I think that that's something that's being prepared now. Thank you. You have answered in part already to the question I wanted to ask about relays. This is unique in Villeneuve. Is it experimental, or is it something that's enacted? Patients who are released, I suppose that there are criteria for strict inclusion criteria. The patient who benefits from this type of treatment, what happens when they're released? Because have you been confronted with patients who've found it difficult? The only patients who've come out who have been released at the moment, I've already called the ARS. We tried to find a solution for them. There are no special criteria. And so we move from one injection to under the tongue. It's not experimental because there's AMM, which is on the market. There was a medicine committee which has enacted this. We discussed about the interest of the medicine, about the treatment, and it was activated for the hospital centre in Montpellier. We also, if I send it in a hospital to hospital, they can receive it. So there's a possibility, but outside of that framework, we have to negotiate with the regional health authorities whilst we wait for the ministry to do something. If patients like this write saying, "I want to stay on the drug," and there's somebody who perhaps will work in different places or will move around, there's this problem of knowing, they will have the problem of not perhaps remembering if they're taking it every day. A final question, because we're almost out of time. Thank you, it was really interesting. Mine was a general comment, more about the support. Isn't there a risk when you propose a treatment that's done once a month of reducing meetings between carers and between health professionals and the prisoner? And so for precarious people, you can see how important this might be. Is that better with a treatment that's taken once a month than something every day? because sometimes the health workers are the only people who will be there to provide support and help. So the risk would be that the help would be reduced. I don't think there's a risk because to date the prescription, the doctor can see the patient every 28 days. That's already the case. There can also be a psychiatric or psychological support, and also there can the patient isn't caught. The patient will have this new sensation of it's good not to take anything for a good part of the month, and that's a new paradigm. We see 2 weeks afterwards for the treatment, and they can be included. There's a talking group. For example, there's one which uses body expression with circus arts. They can be given other possibilities as well, alternatives to invest their time in. Perhaps it's just a way of, releasing nursing staff from such a heavy workload. After 28 days, they go home. In prison, there are prisons which do it on a weekly basis because there were 2-3 hospitals that were closed down. And so even though this wasn't something that killed them, it was simply not having respected the rules. Let's move on to the final presentation now, which will be done by Michel CELSE, who represents the National Council for AIDS. There's a big difference with COVID. Even if the AIDS pandemic was very, very sad and very serious, it pulled us upwards with the appearance of institutions like the National Council for AIDS and financial institutions, with the World Fund, and
Good afternoon. Thank you for I would like to thank the organizers for allowing CNS to present their work, which is part of I would say, a broader question, actually. Let me say a few words about this. Let me say a few words about the background. This is about the prevention treatment of hepatitis C in the prison population. Of course, you know that the direct action antiviral drugs have changed the paradigm of the management of hepatitis C virus. And in terms of public health, we have a possibility of eradicating this virus. So this is something that was understood by the government, which set the eradication of hepatitis C virus by 2025 as part of their priority objectives. In this strategy, as you know, the population in prison, of course, is a key population for this type of epidemics, and therefore a key population for the achievement of the objective. Now, if we consider that a lot of people have no access, direct access to care, so in fact, being in prison offers an additional opportunity to benefit from proper health care. And the last element I would like to mention is that our committee was asked together by the Health Ministry, the Justice Ministry, and other authorities to present a report of the health situation and to consider possible tracks for improvement, particularly in screening. So this is why we produced an opinion document followed by 14 recommendations and an overall report presenting all the investigations that we carried out. This is why the quantitative aspect is going to be presented here rather than anything else. And in line with the current recommendations for screening, the idea was to assess the number of screening tests undertaken by the health authorities and how this is changing or has changed over the past few years, and how new entrants in prisons are being screened. As to the introduction of treatments for all those detainees with an active infection, the situation since 2016 is that any person in prison with an active infection is entitled to direct action antiviral treatment. So this is the situation now, and the idea is also to try to assess the treatment cascade for the people who have just recently entered the prison environment. This survey only considered 3 regions, excuse me, for feasibility reasons. I'm not going to get into the details. You'll find them in our posters, poster number 11 here, or in the actual report. But I'd like to mention 2 factors. We do lack data about the population in prison because there is total lack of epidemiology and management data in the health units. And for that, we have been using, to compensate, we have been using indirect investigation methods, which of course cannot be perfect. So we have been using, for example, the various activity reports, which are administrative reports for budgetary, that are produced for budgetary reasons. They have nothing to do with health motives, but we were able to retrieve some figures and actions. So we also considered the data concerning the pharmacies of hospitals that are related to prison, because no one had any such data actually, even if the social security system should be able to trace these data. And we used various literature data and all the possible data we could get from the prison administrations. So as you can see from this, for these 3 viruses, we have about 50,000 screening tests a year, which is pretty stable and has been so since 2013. In fact, the population in detention has remained stable over these past years. This is why there's not been much change. And besides, the screening results are pretty similar for the 3 populations, the 3 viruses. So we checked in detail each health unit to check our conclusions to make sure that these 3 screening tests were conducted simultaneously and properly, and there is little variation between the data we obtain. The second point is that for the population in detention, 1 out of 2 has a screening test when entering a prison. There are strong disparities between regions for that, and even more stronger disparities depending on each prison. The screening test is usually offered systematically, but in many cases, of course, this is rejected by the person, by the detainee. As far as we know, it may be 2/3 of rejections or refusals. It also depends on where and when this is being offered to the person. But what is very often failing is the actual fact of screening, the actual screening itself. And in particular for the younger population. Besides, we have here a chart showing the number of treatments being dispensed in prisons on these 3 regions. We have, in fact, the changes in the various places, but obviously things happen to evolve differently depending on the region. If you take the dark red column, which corresponds to the east of France, we see an increase and a slight decrease for the Île-de-France region, the Greater Paris area. We have something different with a decrease, a progressive decrease, etc. So it's pretty complex to extrapolate this data on the national level. And then if we try to consider the cascade of treatment and access to treatment in the 3 regions, if we want to better understand this graph, the first bar shows an estimate among the newcomers to prison, that is those being infected by hepatitis C virus, HCV. Dark blue being active patients. So this is therefore about prevalence data on the newcomers to prison. We can see quite clearly that the issue is the lack of screening. That's the major obstacle. The 3 regions only screened 57% of their patients, and we cannot assess the third bar. That is, we don't know how many active patients with a confirmed diagnosis exist, but we just have the figures for those receiving direct action antivirals, DAA. So we can say that between screening and access to treatment, things are not too bad, because we have about 8 out of 10 detainees that can access to treatment. So it seems that things have been improved. I'll be quick on the conclusions, because despite the absence of data, it's still good to consider some aspects, and in particular limits. So despite the lack of exhaustive data, despite everything we try to do to avoid biases and errors on the data, we must acknowledge the fact that the data we have been using are not the right ones for this kind of investigation. And the nature of these data is such that there may be an overestimation, which is even worse. That is that we used hypothesis that screening was done upon entry, but we know that in actual fact there are very few screening tests undertaken in the course of detention. So this creates a bias in our results, and of course this means also that the figures I showed you upon entry is certainly much lower in actual facts. So we just extrapolated, but we don't really know what happens in the other regions. We saw 3 regions with very different figures, and we don't know about the others. And as you saw, this cascade is quite not exhaustive. But there is still nothing to imply that the profile of this cascade should be different at national level. I guess the values might be different, but the profile may not be different. The number of detainees receiving antivirals depend, in fact, on the performance of the screening tests. And the rates we observed in these 3 regions happen to be higher than at national level. It's 57% versus 52%. So, hypothetically, in a national cascade, we believe that the rate of access to treatment should be lower than what we observed over these 3 regions. So, what about the conclusions? It is therefore necessary to organize the routine collection of data from the health units in the prisons, just to adapt the health response in prison. Besides, the low rate of screening is another obstacle, which means, of course, that we have to drastically improve screening if we want to improve the test and treat strategies within the population in detention. First of all, because they have a right to that, and second, because we want to reach the objectives of virus eradication. Do I have some time? I could also show you some qualitative data about the reasons why screening is so difficult. Let me mention maybe 3 reasons. I'm just skipping some of these data. In fact, there is a lack of awareness among I would say, the experts, apart from the people sitting at this table, related to the change of paradigm that occurred with the introduction of direct action antiviral treatments. They didn't understand the interest of the test and treat strategy. So obviously the things have to change for that, because they didn't understand the objective for curing people in detention. They never thought of further screening during detention. Of course, this raises some questions about the role of some of the actors. As to the role of TRODs, also we could consider what this is all about. And I would say that the health units, of course, are in charge of screening, but there are other actors, other stakeholders or partners, whether internal or external, that should be involved to offer a more diverse and more qualitative healthcare offers, so as to perhaps recapture those who didn't want to go through screening. So they could be associations, but also services related to mental health or addictology. And to conclude, well, you know about that. The idea is to become aware, of course, of this paradigm change and to draw the consequences in the combat against HCV. The idea is to be using short systems, internal ones, to reduce the time span. This is something that can be further optimized. A lot of detainees are there for just short periods of time, and the time span remain too long. So installing a treatment within the 2 weeks following screening should be and is a very realistic objective, but this means a lot, actually. Some manage to achieve this, some don't, but it means that a lot of things need to be readjusted. This strategy would be meaningless if we don't improve prevention within prisons. And this is the risk reduction aspect or harm reduction aspect, and the interest also of reduction of risk related to drugs or related to sex, which is very important in prison. But I'm afraid we don't have time to discuss about all these aspects right now. We are currently, indeed, our institution is a bit slow, but I think things are now moving forward and moving faster. Yes, but we also have to consider that the various administrations pursue different objectives, and this is something that we can feel because strategies are many and are regularly drafted and redrafted, but they all fail. And I'm hopeful that your current strategy is going to be successful. Well, for this one, we actually work with the Ministry of Health. I'm sorry, but I have to. I do apologize, but I have to go. I cannot stay longer. Can we take a few questions from the audience? If not, we will meet again at 2:30 with more papers on the subject. So tomorrow at 2:30 we will have talks on hepatitis C.
You asked me a question about the prevalence of hepatitis C virus in juvenile detention centers. And during this session, I communicated with my office. They sent me the following data, and it's indicating that in 2013, there was a study that has been conducted in 18 countries, and the prevalence was 4%. 4%. And among juveniles who inject drugs, the prevalence was much higher, and it was 66%. Okay, that was in 2013. Another study in Europe, it says 36% of hepatitis C in juvenile detention centers. Another one in Australia with almost confidence interval 24%, 38% in another country. So it's around these figures, 4%, and among risk group, it's much higher than that. If you want, I can forward you all these articles. But I was keen to respond to your question, and thank you for that.
Y a-t-il d'autres questions? Non, apparemment.
Do we have more questions? Well, if not, thank you. We would like to thank the speakers and thank the audience for staying with us until now.